Hi all, good evening. So we move on to another session of our toxicology series. I know you all aware of the topic today, but I didn't deliberately kept this first slide as toxic as the name of our program. I don't want to go from the actual topic, then go to pathophysiology, clinical features, investigations, and treatment. That's how we read in textbooks, how usual lectures go. But when we read textbooks in that fashion, you get the informations, you understand the concepts, not the fullest of the concepts, but you get the concepts, you get the clinical features, everything. And when you write the exams, you get the marks, you get pass marks. That's not the issue. But when you comes to clinical scenario, in real world scenario, we often find it difficult to correlate with those findings in our clinical scenario. So we get stuck in some situations. Even I got stuck in some situations. So that's when I learned how to learn things, how to learn our emergency medicine topics, especially toxicology. Toxicology is something, it's very interesting to learn, but very difficult to practice. It's very difficult to be taught also. It's very difficult to practice also, but it's very interesting to learn because as in first session, Dr. Jeevan has told we go like an investigator. We should have a mindset of an investigator when we go in a toxicology patient. Most often in every patient, but in more specifically in toxicology patients. So I don't want your mind to be preoccupied with the topic per se, but we'll be going like how a patient presents to our emergency department and how our thought process go with that patient, how we manage the patient. That's all. So nothing fancy. So we'll be moving on to a session. I don't want you to be in a lecture. I want you to be in your emergency department or in your clinical setting where you work with familiar faces, familiar monitors, familiar surroundings, everything. So that's the scenario. So we move. You are having a clinic shift, ED shift you are having, and it's a calm shift, and your ER door slams open, and a unconscious patient is being rolled into a resus bay or red area, and a lady, who is very anxious, is accompanying the trolley, and seems to be his wife. Okay, and when the patient is being rolled into a resus bay or into a red area, that 1 minute or less than 1 minute, we use that 1 minute to hear what they want to say, not just ask our leading questions, not to get everything from their history, just to hear what they say. That's here she is saying that he was lying unresponsive in his room. We had a quarrel today morning. That's all. No other history, no previous history, no medication history, no history of suicide attempt as well, no bottles either, nothing. Just in textbooks we read like get the history from EMS because every textbooks has been formulated from outside India, so they have a very good EMS system. We don't have that, and we can't rely on that. But what we can rely is that what the exact words that bystanders give us. So we get the history, we get that points. We go to a patient, patient has been already in the red area. So we go to the patient and we move to the ABCD assessment. We always move with the ABCD assessment in every patient in emergency department, whether the patient appears to be stable or not. Because to assess to know whether the patient is stable or not, we need the ABCD assessment. So we move to the ABCD assessment. This is the patient. We move to the airway assessment, and the patient is unresponsive. Patient is responding to pain only, and his airway, its oral cavity is full of saliva. His saliva is drooling out of his mouth. So we know that patient airway is threatened. We will be giving suction to suction. We will be planning for intubation if the patient is not unresponsive, if the GCS is less than 8. So every management to a critically ill patient, every management for a critically ill patient will be done in this patient. But what I want to stress is that we pick those points, we pick those clues that patient is have some CNS symptoms, patient has increased salivation. We pick those findings and take in our pocket. That's it. And we manage the patient and move on. So we got the patient's airway, we got the points, and we are moving to the breathing assessment. In breathing, patient, we ask our staff to connect the monitors and saturation probe. And meanwhile, while the staff is connecting the monitors, We can have a look at this chest wall. How is it taking his breaths? So he's taking his breath more rapidly. His tachypnea is there. He is using his accessory muscles. And when we auscultate, we can see here copious secretions. That's bronchoria is there. Is wild. Crepitations are there. Wheeze can be heard. So these are all findings that we get. Here we collect all those findings. Also, we manage with O2. If the patient is already intubated, we adjust FiO2 to maintain saturation. Otherwise, we'll be moving to O2 mask, NIV, or all those sorts of air breathing management. We've done that. We got all the clues, and we move on to the circulation. In circulation, the first thing we look at was heart rate and BP. So we looked, the heart rate is 48 per minute, BP is 86 or 54 millimeters of mercury. So, and there are signs of shock. He's having narrow pulse pressure, cool, clammy skin, delayed capillary refill time. So that's a classic shock. But something strikes us is that when a patient with shock, we always expect the patient to have a tachycardia. But here we have a patient with bradycardia and hypotension. So that is something where we can narrow down our differentials. So hypotension and bradycardia patients, we don't have much very wide variety of differentials. So in case of toxicology, we'll be thinking of calcium channel blocker toxicity, beta blocker toxicity, digoxin toxicity, organophosphorus toxicity, and patient may have extensive anterior wall MI or inferior wall MI. Those are the main differentials that we'll be considering with respect to the heart rate and BP in this patient. So we'll be collecting those evidences, getting some clues about the diagnosis, and we match all these clues to each and every diagnosis, and we come to a conclusion. So here we will be we'll be putting 2 large bore IV cannula, starting fluids, all those management to become the BP. And here is the point that here we will be thinking that to manage the patient as a symptomatic bradycardia patient. So here the patient is having bradycardia and the patient is symptomatic. So according to ACLS protocols, we will be managing the patient. We will be asking our staff to give the atropine 1 mg, 3 doses. Then we move on to the adrenaline or vitamin infusion, and then to transvenous spacing. So that is the approach that we gain from the ACLS approach of the bradycardia. But when we learn the ACLS approach, one thing I want to emphasize is that ACLS is the most basic thing that emergency physicians should know. We have to build our knowledge from the ACLS platform to gain more knowledge to manage the patient more efficiently. Because at this point, so we saw that patient is having bradycardia. Definitely, we'll be asking our staff to give atropine. So when we ask the staff to get atropine, the staff has to go take the atropine ampule, break the ampule, load it in the syringe, and give that atropine to the patient. So still that time, we won't be standing still beside the patient. We will be using that time to complete our assessment of ABCD assessment. And after the assessment, we will be knowing that this is not just a bradycardia, not just a complete heart block or second degree heart block to be managed with atropine and transcutaneous spacing. This is something else. So we need to know the differentials of bradycardia, what might be the cause of bradycardia, and the cause should be treated. The approach of ACLS buys us time to think and to get into the differentials or into the diagnosis. So here we will be starting with atropine, but we will be completing our assessment during that time, and we'll be going with how to manage that patient, not just a bradycardia. Okay, so we already got those findings. We are done. We are going to the disability part. In disability, patient is unresponsive with a GCS of E1, V1, and M4. He is not responding to that much to the painful stimuli, but movement is there. And GRBC is normal. And looking at the pupils show pinpoint pupils. So those are the other findings. We take that and move to the exposure part. In the exposure, patient is severely drenched in sweat. Patient has a urinary incontinence, urinated, and a typical garlicky odor smell. So everything we collect all those findings with us. There's salivation, excessive salivation, bronchoria, bronchospasm, profuse sweating, bradycardia, hypotension, meiosis, increased urination, altered sensorium. So everything points to a cholinergic toxidrome. And whenever we get a cholinergic toxidrome, the first and foremost thing that comes to our mind is the organophosphorus poisoning. So this is the clinical features that we find in a organophosphorus poisoning. So there are mnemonics to learn that. That's a sludge M. It's a salivation, lacrimation, urination, defecation, GI cramps, emesis, and meiosis. And killer bees are there: bronchoria, bronchospasm, and bradycardia. These are those findings that may kill those patients. So these are the findings. We collect those findings, reach a toxidrome, and we treat that toxidrome or the poisoning that most commonly causes that toxidrome. Yes, yes. So in the same shift, we get another patient. That's case scenario 2. A middle-aged man is brought to our ED with multiple episodes of vomiting, loose stools, and followed by he when drowsy. That's a history. When you look at the airway, he's drowsy, he's responding to verbal stimuli, but he's drowsy and irascible. And he is having mild secretions over his mouth, frothing is there. Heart rate is 52, BP is 90 over 60, respiratory rate is 16. So it all points that maybe the patient is having a acute gastroenteritis. The patient has acute gastroenteritis, went into severe hypovolemic shock. BP is hypotensive, patient is hypotensive, and skin is cold and clammy. But when we look at the patient, we have few more findings, because when the patient is hypotensive due to hypovolemic shock, we more commonly expect the patient to be tachycardic, but the patient is bradycardic, and he is having increased salivation in his mouth, increased secretions, so increased sweating over his body. So we don't expect a patient with hypovolemic shock to have a finding of increased secretions of his body, and his pupils are pinpoint. So that doesn't match, and we tend to think outside the box of an acute gastroenteritis. And when we find that these are those muscarinic symptoms that can be associated with organophosphorus poisoning. So this is how patient may be deceptive in some scenario, but careful ABCD assessment can help us to think correctly. So we can have a differential of organophosphorus poisoning in this patient also. We will be taking proper history and we will be moving on. That's the second case. We have another case scenario. The same shift, another 28-year-old male is brought to our ED with same complaints. It's multiple episodes of vomiting, loose stools, and he went drowsy after profuse vomiting and loose stools. But the findings are not the same. He's having a heart rate of 125. He's tachycardic. BP is 170 or 100. That also disparitic. So pupils are bilaterally dilated, reacting sluggishly. Skin has profuse sweating, and GRBC is normal. And in CNS examination, he is drowsy, responding to verbal stimuli, but he is having generalized weakness and fasciculations are present. So this also doesn't fit exactly to the two scenarios that we already have. This is something else. But the patient has symptoms of gastroenteritis. Patient can go into shock, but the patient is having hypertension. Also, patient is having increased sweating. So can this be OP poisoning? That's my question. This also can be OP poisoning. So what are the symptoms that we can have because of the OP poisoning? So first group is that the patient we got in the first place, that's the increased secretions because of the muscarinic effects of the cholinesterase inhibition. That's the first case. We have secretions all over the body with meiosis. Second is the nicotinic effects. That's the muscle fasciculations, weakness, mydriasis, tachycardia, hypertension. And third is the CNS effects. Patient can be anxious, patient can be confused, patient can have seizures, patient can be disoriented, anything, any findings of the CNS findings can be seen. So mixture of these findings will be seen in a OP poisoning patient. And some symptoms, some group predominates over the other. That's happened in the first and second place, where the muscarinic symptoms, the increased secretion phenomenon, predominated over the nicotinic symptoms. In the third patient, nicotinic symptoms predominated over the muscarinic symptoms with CNS effects in both the patients. So all these three patients are possible OP poisoning patients. So we have to go through a clinical examination ABCD assessment correctly with these findings in our mind to catch those OP poisoning patients. Okay, so we correctly identified the cholinergic tox syndrome with respect to those patients, and now we are thinking like, why the patient? What is happening in those patients? What is the pathophysiology in that patient? That's how we think when we see the clinical features in a patient. We don't just go. That's when we think of pathophysiology. What's happening inside the patient? So what's normal physiology? Whenever there is a stimulus, the stimulus comes to the presynaptic nerve terminal, and acetylcholine is released into synapses, and the acetylcholine binds to the postsynaptic receptors, could be muscarinic receptor or nicotinic receptor. It gets binded, and the stimulus is passed on. So that's how the effect is seen. And there is acetylcholine esterase in the synapses, which breaks down acetylcholine to terminate the signal. So when we have to terminate the signal, we don't need more stimulus to go on. The acetylcholine esterase breaks down the acetylcholine, no more stimulus is going on. That's how normally functions. When we have an organophosphorus compound or any carbamate compound ingested into the body, it binds to the acetylcholine esterase and blocks the enzyme. So the enzyme won't work. The acetylcholine levels increases in body, in the synapses, and it continuously stimulates the receptors. So the accumulation of acetylcholine in the synapses causes the increased stimulation, overstimulation of the receptors. That causes that wherever there are receptors, the stimulation will go on. So receptors are finding muscarinic symptoms, muscarinic areas, that's meiosis, salivation, lacrimation, bronchoria, all those findings will be seen. When it acts more on the somatic nerves, we can have fasciculations, which progress to weakness, paralysis, and lend to the respiratory failure. When it moves to autonomic ganglia, patient will have hypertension, tachycardia, arrhythmias. In CNS, patient can have anxiety, confusion, seizures, coma, and even respiratory depression. This is what happens with when a patient ingests in organophosphates or carbamates. And there is a concept of aging because carbamates binds to the acetylcholine esterase reversibly, but organophosphates binds to the acetylcholine esterase irreversibly. But it takes some time for the organophosphates to irreversibly bond with acetylcholine esterase. And this process is called aging. So some organophosphates can reach the aging process very fastly. So the irreversible bond is made very quickly. So it's very difficult to break that bond when the patient presents lately. That's the concept of aging. So we understood what is happening inside the patient. Patient is having cholinergic tox syndrome. How is that happening? So now we move on to manage the patient. So we all know what are we giving? Atropine. Atropine is the drug of choice that we give in OP poisoning patients. But why atropine? What is the atropine doing in there? Does the atropine neutralizes the organophosphates that the patient has ingested? Or does the atropine decreases acetylcholine levels that's causing the symptoms? No. The atropine comes inside the synapses in large amounts and it competes with acetylcholine to bind with the receptors. That's happening. So it blocks only the muscarinic receptors. It competes only with the muscarinic receptors. So it reverses only the muscarinic manifestations. So we have large amounts of organophosphates in the synapses. So we are giving atropine to compete with the organophosphates. So we have to give large amount of organophosphates, atropine to compete with the organophosphates. So how do we dose that? Usually we start with 1 to 3 mg of IV bolus and we double the dose every 3 to 5 minutes to achieve adequate response. That's how we go. We start with 2 mg. You look for 3 to 5 minutes. There's no response. We give 4 mg, then 8 mg, 16 mg, 32 mg, 64 mg. Like that, we move on till we get an adequate response. What is the adequate response? we want the patient to be hemodynamically stable by giving the atropine. So to be hemodynamically stable, he has to have a dry chest because the bronchoria has to be resolved. So the oxygenation could happen correctly. He should not have a bronchospasm. Then only the oxygenation will happen correctly. He has to have a heart rate of more than 80, and then BP has to be more than 90. So hemodynamically stable patient. So that's how we measure the atropinization. No other measurement can be helpful in stopping the bolus dose of atropine. These four findings only can help us in stopping the initial dose of atropine. So in children, the dose is 0.05 mg per kg IV bolus, and we move on to increase the doses. And when we have achieved the adequate atropinization, we move on to maintenance. So do we need a maintenance? That's the first question. Why do we need a maintenance dose of atropine? Because we gave the bolus doses, atropinization has been achieved, patient is hemodynamically stable now. Now, why are we giving more atropine? So the answer is organophosphorus remains in that area, in synapse, in blood for more longer time than the atropine that we gave. So now the atropine has acted. When we stop giving atropine, the effect of atropine wanes off. And at that point, the already existing organophosphates takes over again and symptoms reappear. So to avoid that, we need maintenance dose. So we calculate a loading dose, bolus dose that already being given, and start infusion with 10 to 20% of that total loading dose per hour, and regularly assess for the symptoms. So in situations like this, we may have to give a large dose of atropine. So don't be frightened about the dose of atropine that you have to give. Just be frightened about the persistence of symptoms that patient have, even though we give atropine. So we have decided to give lots of atropine. That's okay. And we started with 2 mg. Patient, we asked the staff to give 2 mg atropine. So staff has broken 3 ampules of 0.6, which gives 1.8 mg. We asked to give 4 mg, then 8 mg, then 16 mg. When you start to ask more, when you are about to ask 32 mg, the sister just looks at you. Just do I have to break more dozens of ampules to give? Because every 5 minutes, every 3 to 5 minutes, you are asking to break more than dozens of ampules. So is that how you give atropine in atropine boluses? So it's that point I want you to be aware of how the atropine formulations, how many atropine formulations are available in your emergency department. One thing for the first one is at ampule, which is 0.6 mg per ml, which is more common, very common to you all, because we will be giving that in symptomatic bradycardia. Just break the ampule, we'll getting 1.6 ml, 0.6 mg, give that. Second one is a single dose vial. We have 1 mg per ml. That's also easy. 1 ml contains 1 mg. We can give that also. For the initial stages, these are enough. We can have a single dose vial or ampule, which will be already kept in the resuscitation bay. We can use that to start with the lower doses. But when we need higher doses, we may have to move on to multi-dose vial. So we ask our staff or any other staff to collect that multi-dose vial from the pharmacy. You can ask this only if you know that your ED is equipped with other formulations like multi-dose vials or infusion formulations of atropine in your ED pharmacy. So we have to be aware of those formulations are available. The formulations may be different in different EDs with different scenarios, but you should be knowing which is available in your ED. So we have a multi-dose vial which contains 20 ml. 20 ml contains 8 mg, and infusion is also there. 50 mg, 100 ml. Variations can be there. So be aware of these formulations. Make use of those formulations to give larger doses. And you gave the large doses atropine, and patients still have the muscarinic symptoms. Patient is having bronchoria, bronchospasm, bradycardia is still persisting. Bronchoria, bronchospasm is there, but patient starts having hallucinations. Patient is very much agitated. He is speaking his IV lines. He cannot be maintained in ED at that point. So So patient is starting developing what CNS symptoms, atropine psychosis symptoms, when we give large bolus doses of atropine. So what are we going to do at that point? Should we stop atropine? Well, the textbook says when atropine is not enough, think glycopyrrolate. So the glycopyrrolate is also medication of muscarinic anticholinergic group. It does not cross the blood-brain barrier and consequently has consequently no central effects or few central effects. But the actual dosage of glycopyrrolate or actual usage of glycopyrrolate over atropine has not been formulated so effectively. So each ml contains 0.2 mg. You can give a glycopyrrolate, but we cannot stop atropine because atropine is the drug of choice or antidote for the OP poisoning. So we have to get atropine, but when the patient develops atropine psychosis, what we can do is that we can just stop the atropine for a while till the atropine psychosis settles. Till that time, we can give glycopyrrolate, and then we continue with atropine on lower doses and go on with atropine plus glycopyrrolate. Or another practical approach is that if the patient is so much agitated, so much psychotic, we can paralyze the patient with intubation, mechanical ventilation, give adequate sedation, and move on with lower doses of atropine and glycopyrrolate. But glycopyrrolate alone will not do the job to save the patient from OP poisoning. But textbook says that when atropine is not enough, think of glycopyrrolate. So that's how we identified the cholinergic toxidrome. We know the pathophysiology. Now we have started the treatment with atropine. Atropine, how much atropine has to be given, how to be given, and think of glycopyrrolate. And we move on to the another group of drugs, that is oximes. Oximes are those group. How the oximes work? Oximes, the acetylcholinesterase and organophosphates creates a phosphorylated bond between them, and the oximes that comes into body dephosphorylate, cleave the phosphate enzyme bond and reactivate the acetylcholinesterase. This reactivated acetylcholinesterase can reduce the levels of acetylcholine and improve the symptoms. The important point here is that when we give atropine, atropine reduces only the muscarinic symptoms. But oximes, when oximes are used, oximes can regenerate acetylcholinesterase. So it can improve the nicotinic symptoms as well, along with the muscarinic symptoms. So oximes are very good in view of the mechanism of action, how they work. But the issue is that timing. Timing is very crucial because we know the concept of aging. Because when the when the bond is aged, because the bond is already formed irreversibly, it's very difficult to break even if we give the oximes. Some organophosphates forms the bonds very easily. Some takes so much time. When it takes so much time, we can give the oximes and break the bond, gets a reactivated acetylcholinesterase and improve the symptoms and save the patient. So timing is very crucial. As early as possible, give oximes. And the recommended dose of pralinoxim is 30 mg per kg IV bolus given over 20 to 30 minutes and followed by IV infusion of 8 mg per kg per hour. So it takes time, it takes 24 to 48 hours for the symptoms to resolve. So we have to continuously monitor the patient with acetylcholinesterase levels and symptoms. So that's how oximes work. But the issue, major debate or OP poisoning happens around oximes. That doesn't happen lately. It's happened earlier also. There was so much debates. And the progression has been like that. In 1996 itself, there was in comparing of atropine plus paradoxine combination versus atropine alone in OP poisoning. And it was found out that atropine alone was as effective as atropine plus paradoxine in treating acute OP poisoning patients. So when it comes, then studies goes on. Then 2002, there was a study on continuous versus bolus paradoxim, and it shows that early continuous paradoxim infusion, that's more than continuous, it's early paradoxim infusion, improved the survival compared to the intermittent boluses. And there has multiple meta-analysis came on in 2020 and 2021. In 2021, it was shown that there was no improvement in survival or need of ventilator support with paradoxim. Rather, it showed an increased incidence of intermediate syndrome when we gave paradoxim. In 2021 also, they had a discriminating use of paradoxim, especially when given in early stages for a moderately to severely poisoned patient. So it was a not it's a contradictory findings that we get from every scenarios. But in 2023, the life-threatening poisoning guidelines says have a more diplomatic approach, like consider early oxygen administration in significant OP poisoning. And oximes are not universally effective. But in our scenario, in our third patient, we had a third patient with more of a nicotinic symptoms, where muscarinal symptoms were not that predominant. We have to go with oximes, because if we give atropine in that patient, we won't be improving the patient symptomatically, because those symptoms will not be corrected by the atropine. Those patients should get oximes, right? So that's what AHS says, that consider early oxime administration in significant OP poisoning patients with fasciculations, weakness, or paralysis. That's the patients with nicotinic symptoms predominates. So that's how we can go start oximes early. And when you have nicotinic symptoms, think of oximes. Atropine is the drug of choice that we always get. So we collected those evidences, we identified the cholinergic shock syndrome, we started on the atropine and oximes, and now atropine infusion is going on, paratamsine infusion is going on, patient has improved so much dramatically. Patient has been stabilized. So we decided to shift the patient to emergency medicine ICU, emergency department ICU. Patient is being continuously monitored over there. Next day, we come for the rounds, morning rounds. Vitals are stable, patient is talking, and we ask the patient to lift his head up from the bed, and patient is unable to do that. So that point, we are thinking of pathophysiology again. So there is something wrong with that. Oh, sorry. We have to do something. There is one investigation that we have to go, because we don't wait for investigations to come, or when we have such a patient, we tend to start the treatment. But the one investigation that we have to confirm, not to confirm, but to check whether the patient is having OP poisoning or not, that's the cholinesterase levels. So we have two types of cholinesterases. That's a butyryl cholinesterase and acetyl cholinesterase. Butyryl cholinesterase is produced in liver and secreted into blood. And this is the cholinesterases that metabolizes xenopathies, the drugs that we take. Example like succinylcholine, cocaine. So this has been metabolized by the butyryl cholinesterase. The acetylcholinesterase, we have two types of acetylcholinesterase that can be in red cell, which is bind to the red cell membrane. And the second is a neuronal acetylcholinesterase, which is secreted in the synapses. And this hydrolyzes the acetylcholine at the synapses. So the level of acetylcholinesterase correlates more with the patient, but easy to get the results is the butyryl cholinesterase. So when a patient takes a patient has significant exposure, the butyryl cholinesterase levels usually falls first and followed by decrease in the red cell acetylcholinesterase activity. Similarly, the regeneration happens, butyryl cholinesterase regenerates faster than the red cell acetylcholinesterase. So we know that, and we are about to send the investigation. We ask our staff to, Sister Ji, please send acetylcholinesterase level. So she's asking how to send, which bottle you have to take. Is it a red bottle, blue bottle, or EDTA bottle? So in butyryl cholinesterase, we can use the red bottle. That's a plasma containing bottle. There's no anticoagulant. And in that butyryl cholinesterase, the organophosphates patient ingested or the oximes that we gave will not significantly interfere during the storage. So no need of any immediate dilution or cooling is needed for the butyryl cholinesterase levels. That's why it's easy to be done. But in case of red cell acetylcholinesterase, it has to be collected in an EDTA bottle, and the OP and the oximes can interfere with acetylcholinesterase levels. So we have to be immediately dilute the blood, and has to be rapidly freezed. So that's how blood sampling of cholinesterase assay is done. And after the results, we get a decreased level of cholinesterase. That doesn't always mean that the patient is having decreased OP poisoning. So, patient is having OP poisoning. The decreased level can be seen in pernicious anemia patient with antimalarial or antidepressant drug therapy, hemoglobinopathies, liver disease patients, pregnancy, or another genetic deficiencies. So we have to be aware of this cholinesterase. We send that levels also. So after that, we'll be shifting the patient to emergency ICU. And during the rounds, what happened? The patient was unable to lift his neck. So that is the intermediate syndrome in OP poisoning. The OP poisoning He had an acute cholinergic crisis. Atropine oxygens are given. Cholinergic features are resolved. And within 24 to 96 hours, the patient develops proximal muscle weakness or neck flexor weakness or cranial nerve palsies. And this progresses to the respiratory failure. This is the intermediate syndrome. So why that intermediate syndrome is happening? So when the patient had increased acetylcholine levels at the neuromuscular junction, the receptors are working overload, and then the receptor downregulation occurs, and the recovery takes time. Even if we cleared the poison, even if we cleared the OPs from the area, it takes so much time to recover that overstimulation. So till that time, the patient may have weaknesses. That's the intermediate syndrome. So the patient may have some neck weakness or proximal muscle weakness, cranial nerve palsies, and that whenever you see that, you identify this weakness, you have to be it has to be in your mind that patient may progress into respiratory failure. So immediate airway protection, that is the patient should be intubated and ventilated, and we give the time for the recovery with the intubation. So after the recovery, we can extubate the patient. Patient will be better. That's how we treat the intermediate poisoning. No point in giving again atropine or allantoxin, because it's not because of the increased levels of organophosphates in the area, but just because of the overstimulation that already happened. That's intermediate syndrome. So we already not identified that muscle weakness. We intubated the patient. We kept the patient for 4 to 5 days in our ICU. Patient improved. Yeah, patient is very well okay to be discharged. So we discharge the patient well and okay. We have managed the intermediate syndrome also. After a few weeks, the patient comes back to emergency, and you see the patient coming. You may be thinking the patient is coming to thank you because you saved his life, but he's coming and saying that he's now having several features like numbness or tingling sensation over his feet and hand. He's feeling that his weakness is rising over his legs or arms. So do this has something to do with organophosphorus poisoning that happened earlier weeks before? Yes, it can be. So it is the organophosphorus induced delayed neuropathy. So what is the pathophysiology? We are again thinking what is happening inside. So neuropathic OPs, organophosphates, can inhibit the neuropathy target esterase enzyme, and which causes the axonal degeneration in the body. And this presents as the peripheral neuropathy, which occurs days to weeks after acute exposure, or more commonly, more than with a chronic exposure to certain OP compounds. There has been more outbreaks has been given in the articles that the OPs through some supplements has been given, and supplements has some OP poisoning that has contaminated, that caused the outbreaks. Some contaminated foods has caused the outbreaks. So that has often happened. So when we see this vague distal muscle weakness or pain or neuropathy-like symptoms weeks after OP poisoning, we think of OP-induced delayed neuropathy. But not only this, we have to do an electromyogram, identify what type of neuropathy is this, or differentiate it from similar presentations like Guillain-Barré syndrome. And it takes time to improve, because the treatment is just like how we treat a neuropathy, no specific treatment, just like to be done for a organophosphorus induced delayed neuropathy. Treat the neuropathy, it takes time to improve. Some patients may develop residual paralysis or residual symptoms also. So this is how a pattern of organophosphorus poisoning has to be moved. We identify the cholinergic toxidrome, which includes the muscarinic symptoms, nicotinic symptoms, and CNS symptoms. We think of the pathophysiology. We start with atropine, how to start atropine, how to monitor the atropine. We give oxims. We know about the intermediate syndrome and OP-induced delayed neuropathy. So this is the management and clinical features of the organophosphates. So I didn't mention about the decontamination part of this, because it's already been dealt in the first session. Decontamination has to be done, because before decontaminating the patient, we should be in a PPE at least. We should be wearing a gown, boot car, glove, face mask, head cover, everything, and the patient's dress should be removed, and it should be considered as hazardous waste, and patient should be cleaned with running tap water and that water also should be considered as hazardous waste. That's how we decontaminate the patient. And there are some another studies also going on regarding newer medications, but atropine stays the main treatment for the OP poisoning. There has been studies showing magnesium sulfate can be useful in several situations where atropine and noxims has not worked. In ICUs, we can give magnesium sulfate also. There has been studies showing clonidine being useful. Fresh frozen plasma FFP has been also tried, but its benefits has not been clearly emphasized. So newer studies are also going on regarding the OP poisoning. So this is the overview of organophosphorus poisoning. And thank you for listening. And if you have any doubts, feel free to ask in the groups. We will be happy to address you, and follow us more for the be with us for more updates, more classes. Thank you so much. If you have any doubts, you can ask. So thank you so much. We'll be